Hi, good evening, everyone. Welcome to this ICS webinar. Today we'll be talking about ACO, asthma-COPD overlap, which has had several changes in name. Today is a very auspicious day in the south, especially in Tamil Nadu, where we are celebrating something called Kartika Deepam, which is the equivalent of Deepavali in the north. And it commemorates the appearance of Shiva as this enormous pillar of fire, where both Lord Vishnu and Lord Brahma were unable to get to the bottom or the top. A well-known myth in Hindu culture. But the important thing is it's a pillar of fire which casts a lot of light. And we hope today we will be casting light on this topic, which has often undergone several changes in nomenclature. So we had ACOS to start with, then they said it's not a syndrome, so they called it ACO. The gold guidelines refer to as COPD-A, and the GINA guidelines refer to as asthma plus COPD. So we've had lots of changes here. We're very grateful to the ICS, in particular, Dr. Rakesh Chawla and Dr. Amita Nene for giving us this opportunity to address this very interesting topic. We already have more than 1,700 logins, and we hope they'll increase as time goes on. And we have an absolutely wonderful panel, whom I shall introduce after we hear from Dr. Ravi Dosi, who's going to give us a talk on ACOS or ACO or whatever it is, and then we'll go ahead with a panel discussion. Over to Dr. Ravi Dosi, who's the HOD and consultant chest physician at the Kokilabai Dhirubhai Ambani Hospital in Indore. All of you know him. Everybody knows him, not only as a pulmonologist, but as this amazing actor. He's got multiple degrees and diplomas, and his special areas of interest are allergy, asthma, sleep, and interventional pulmonology. So he was earlier the HOD at Indore and in charge of the COVID hospital in Indore with over 75,000 cases handled by him. He's been the ex-National Secretary of the Chess Council of India, the member of the IMA executive body in Indore. He's a very active campaigner against air pollution, and he has a huge number of followers on his YouTube channel. Over to Dr. Ravi Dosi. I always refer to him as Rockstar, and we're going to hear a Rockstar's performance today. Over to you, Dr. Ravi.
Thank you, respected Dr. Murli Mohan sir, for this very kind introduction. Sir, it's always special coming from you. I would like to begin by thanking ICS, particularly Dr. Amita Nene ma'am, for giving me this opportunity, Dr. Rakesh Chawla sir, and all the GB members who in cohesion are working for the betterment of chest medicine as a whole. Now, starting with today's topic. Yeah, sorry for that delay. Well, as sir very correctly told, the very interesting part of this particular disease, or which we refer to as ACO now, is that it has undergone such a lot of changes. And I think all of us, when we sit down and see a patient in our OP, actually cross this factor of thinking that our patient might actually be suffering from ACO in practically every patient that we deal with. Well, we know where asthma and COPD originate with, but echo we tend to put in our mind as something which might be in between, something which might be originating, having a bit of this and a bit of both. But there are several studies and researches which show that echo in itself also might be an entity. But again, there is further research to criticize that particular thought process and say that it is not an independent entity. So where is all of this confusion and where is all of this thinking and rethinking in this asthma COPD going, and what is its relevance in clinical practice? Something which we all feel is very important that we should understand. Well, asthma and COPD both are very common chronic pulmonary conditions. Both the diseases have considerable heterogeneity, but they share many clinical features. Asthma is prevalent in 27%, COPD in nearly 33% of the world population. But this asthma COPD which we are talking about is prevalent in around 1% to 5% of the total population. So we need to understand that it's not every patient who is going to go that way. It will be a select few in which we'll be actually thinking and labeling them as echo. So up till now, as a part of preparation of this particular webinar, I went through several papers and I could gather around 18 definitions for echo. But don't worry, I'll be only talking about the one which is published in the standard guidelines. But what is the general thing that we should accept as this will be echo? It is that a fixed airway obstruction depicted by a post-bronchodilator FE1 FEC ratio less than 0.7. That practically applies in all the definitions. Usually, the age is more than 40. The patient might be having a history of smoking or any other known biomass exposure or another risk exposure. There may be a patient reported diagnosis or a physician diagnosis of asthma, a bronchodilator reversibility of more than 200 to 400 ml, a presence of significant sputum or blood eosinophilia, and the documentation of wheezing or an atopic disease. We see that practically these clinical features are present in most of the patients in which we will or we can label them as echo safely and take them on that particular treatment pathway. This is a very essential slide which depicts how from the period of fetal uh, growth to neonatal growth, the so sorry from fetal growth to neonatal growth to childhood, several risk factors play a role in the development of asthma and COPD. While we see that there is a strong genetic predisposition which is to be there in asthma, in COPD there is predominantly an environmental exposure which is there. As a person grows more older, we see that relative proportions of different risk factors come in, like smoking, environmental factors, tobacco exposure, and infections becoming more important in the adolescent, adult, and age group. Whereas in fetal, neonatal, and childhood, the important risk factors to the development of conditions like echo include infection with respiratory syncytial virus, parainfluenza virus, the smoking by the mother, or intrauterine growth retardation. We also see that nutrition has an important role to play, and children who are relatively malnourished might be predisposed to develop echo in further ages. There are several studies, one of few of which I'll be quoting further, which show that children who take up smoking early might in future be predisposed to develop echo earlier. So with this slide, we can understand that the usual risk factors which we associate with asthma and COPD when exposed at a particular age or time may lead to the onset of echo. Well, we are all aware whenever we used to enter our pulmonary postgraduate program, the first book which we used to open was usually Fishman. And in Fishman, inadvertently, the page which used to get open was the Venn diagram. We always used to see there are so many overlaps which are there. And we would always pinpoint on the fact that there is an overlap in between asthma, COPD, and emphysema. Well, this particular segment is where we should concentrate on, because that is where echo actually lies, and this is that proportion of patient in which we need to think about our current topic of discussion. But it isn't that much only. Nowadays, we go further and we see that echo is even having a huge amount of overlap from both sides. That means asthma, which can be of eosinophilic, non-eosinophilic, can overlap with COPD. Type 2 or non-type 2 asthma may overlap with COPD, and you can have a emphysematous, non-emphysematous COPD overlying with an asthma, or you might have a frequent or a non-frequent exacerbator overlapping with asthma. So this gives a lot of variety to the type of echo that might come to you, and that it adds to the variety of the patient in which we should think about echo. One another interesting or very relevant point is how COPD overlaps with several different conditions. Like COPD might be existent with asthma in echo. It might also be overlapping with bronchiectasis, causing a condition called BCO. It might be having coexistent fibrosis, or it might be even overlapping with OSA. We commonly see such conditions, and therefore this adds to the interest in the nature of echo as if it is not a separate disease but an overlap of a pre-existing disease. So it adds to the variety of echo, and that is why the echo discussion becomes very, very relevant. Well, there are several features which we see are present, like childhood onset atopic asthma. It may be present in echo. Atopy, allergy, and family history is present in around 64% cases of echo. Occupational asthma is not very common. Allergic rhinitis is seen as almost half of the cases. We do see FEV1 and airway hyperresponsiveness. Sputum eosinophilia is seen. We usually see that exacerbations are present in nearly 33% of patients. Predominantly, they will be of chronic bronchitis variety with the inflammation or inflammatory markers like CRP and interleukin 6 being raised. There are a lot of multimorbidities or comorbidities which may be seen with echo, and they are relatively corticosteroid insensitive. This part is a little difficult, and we have several phenotypes in echo itself and phenotype based management of echo, which we will be discussing further. Now, what the GINA or gold criteria in 2014 did is that it defined echo as to be more likely COPD if onset is more than 40 years, persistence of symptoms is there, or it can be more likely asthma if it is less than 20 years or variation in symptoms. There are several common features of both the disease which were documented, but what they told is if there are more than 3 items present for either asthma or COPD, the patient is likely to have that disease. And a similar number of items for asthma and COPD, both if they are present, then it will be more possible that the patient is suffering from echo. Believe me, this is the simplest definition of echo that I found. All the other definitions were still very, very complicated. So let's try to make it a little more simpler. Well, what we know that echo exists in somewhere in between asthma and COPD. But there are several the phenotypes or endotypes of echo. What are the chronic ones? It can be eosinophilic, it may be asthma in smokers, it may be non-smoker and biomass fuel exposed echo, it can be neutrophilic echo, or it can be an echo in which you see predominantly COPD types. This is one of the most common ones. So what GINA did is it gave a way as how to go ahead with this. But I would like to very clearly mention that the latest guidelines actually don't contain a lot about echo. Most of the work was done in between 2014 to 2023, subsequent to which there is not a significant mention. So suppose you get a case of echo, what do you go or how do you go about it? First of all, diagnose chronic airway disease. Do the symptoms suggest chronic airway disease? If they do, try to see what is the age of onset. Is it below 20 or above 40? Is there variation in the symptoms? Do the symptoms have a diurnal variation? Are they triggered by common factors like exercise, emotions, or is the patient having chronic cough and sputum production? What is the lung function? What is the lung function in between the symptoms? Is there any past or family history? What is the time course of the illness? What is the radiology? Because up till now, we need not only a historical but even a radiological and a spirometric contribution to the diagnosis of echo. Following which we form a diagnosis of echo, which can be having either features of predominantly asthma or it can be predominantly COPD. Following which a spirometry is performed, and if your FE1 by FVC is less than 0.7, then you go ahead with a diagnosis of and treatment of echo. So depending on these particular historical things, several phenotypes of echo have been defined. It can be a non-smoking asthmatic, predominantly a young female or older asthmatic with airway remodeling. It can be a smoking asthmatic, again a young female predominantly with strong family smoking history and atopic features, or it can be a COPD with eosinophilia, or the phenotype D, which can be a COPD with significant bronchodilators seen in older males with an eosinophil count less than 300. Depending on all of this, we can prescribe them relevant inhaler management. The initial evaluation, a complete history, looking for common things like cough, production of sputum, dyspnea, recurrent respiratory tract infection, exposures to environmental hazards, or prior diagnosis of asthma or COPD, and on the physical examination, finding symptoms correlating with either asthma in the form of polyphonic bronchi or a fixed monophonic wheeze in the form of COPD. Whenever we undergo a radiological examination of these patients, the chest X-ray may be normal or it may be showing hyperinflation. The chest CT may be showing some changes of emphysema if there is a predominantly COPD type of a diagnosis. Again, there are several spirometric features which may be present, but those consistent with the diagnosis of echo include a post bronchodilator FEV1 by FVC less than 0.7 or a post bronchodilator FEV1 more than 80%, or a post bronchodilator increase of FEV1 more than 12% and 400 ml. There is a significant role of imaging. Sorry for the badly edited slide, but in imaging, we can use modalities such as CT and even MRI, which contribute to the knowledge of how the air spaces are, what is the nature of the airways. We can assess air trapping. We can even assess small airway function on that particular MRI, and it gives a very sensitive marker of early small airway abnormality. Although this is restricted more to a research aspect rather than clinical application, indirect assessment of small airways by air trapping and by seeing what is the difference in the particular resolution of the CT or lung attenuation, we can assess air trapping and small airway disease. They can help in the diagnosis of echo. But there are some advanced stuff also. Biomarkers are used in asthma, COPD, and echo for diagnosis. They help in endotype identification, confirming the diagnosis, severity evaluation, for therapeutics as to the treatment response, for monitoring the treatment and the prognosis. The conventionally used ones are fractional exhaled nitric oxide, blood and sputum eosinophilia or neutrophilia, spirometry like we just detect, and IgE. And there are even some more novel tools which include molecular sequencing, real-time PCR. These hybrid methods help in endotype identification, personalizing the therapy, and more precise outcomes. So, when a patient is diagnosed historically, spirometrically, if he has an age more than 40, smoking is there, then you should consider echo. Some other diagnostic pathways are also there, which include if there is asthma symptom with smoking history and a fixed airflow limitation, you give a oral steroid test, you go for a bronchodilator test and a methacholine challenge test, then also you can diagnose echo. On the basis of methacholine, you can even diagnose for eosinophilic inflammation and further go for a biological therapy, which we'll be talking about now onwards. Now, pharmacological therapy in echo, most important thing is the history. Identify, trigger, and limit the patient's exposure. Advise smoking cessation irrespective of asthma or COPD. Avoidance of biomass smoke, pollution. Deliver patient education. Ensure adequate inhaler technique and identify underlying comorbidities. Once you identify and initiate a patient for treatment for echo, see and assess, control the triggers, assess the biomarkers like blood eosinophils, Ig and FeNO, assess symptoms, exacerbations, and treat whatever the comorbidities are there. Whenever you are initiating treatment, most commonly we go for inhaled corticosteroid LABA combination. And if it doesn't respond, we have other options like long-acting muscarinic agonists or azithromycin, phosphodiesterase inhibitors, or biologicals. I had showed this slide earlier and showed that there are four types of phenotypes of echo which these patients are divided into. Well, the treatment is also given accordingly. If it is a non-smoking asthmatic, you can go for inhaled corticosteroid, add LABA or triple therapy. If it is a smoking asthmatic, you can prefer a medium dose of ICS, LABA or triple therapy. If it is a COPD with eosinophilia, you can prefer triple therapy, like it was discussed so beautifully by Dr. Nagarjun in the last webinar of ICS. Or if you have a patient with COPD lacking eosinophilia, then you can go for a LAMA-LABA combination, and if not, you can go for a triple therapy. All of this can be done by seeing the age, gender, and what are the severity of symptoms, and whether your diagnosis is tilting more in favor of asthma or more in favor of COPD. You should always try to initiate in a stepwise way, and inhaled corticosteroid LABA combination is usually the first treatment that is prescribed. we see that there can be the presence of both T2 as well as non-T2 airway inflammation, and there are several targets which can be used and which are used in biological medication, which is to be prescribed in patients not responding to your conventional inhalation therapy. Some common and important targets which have been studied in echo are mepolizumab and benralizumab, which act on interleukin 5 and interleukin 5 alpha receptor, and dupilumab, which acts on anti-IL, which acts as an anti-IL4 or anti-IL4/13 blocker. Now, biologicals usually what have been studied extensively are mepolizumab. There have been two studies, Matrix and Metrio. Both of them show that once mepolizumab is used, there has been a reduction in the exacerbation rate and the time to exacerbation. Both are seen. And similarly, studies have been done in the Terra Nova trial and the Galathea trial on benralizumab to prevent COPD exacerbations, both showing that benralizumab, a biological which we know has been commonly used in asthma, has very good or helps in prevention of COPD exacerbations also. Apart from this, there has been the study of omalizumab in patients with asthma COPD overlap directly, and it has been shown that omalizumab is successfully improving pulmonary function tests and giving lower exacerbation, lower hospitalization, and a better asthma control test as far as echo is concerned. But you have patients who still are not responding, patients whom still you cannot define or control. In those patients, you need to see whether their sputum has neutrophilia. They can be smokers, they can be suffering from atypical causes of echo like mycoplasma, chlamydia, H influenzae, or this eosinophilic COPD might not be responding to your inhalational treatment. In that condition, we should look towards a commonly used antibiotic, which is macrolide. Macrolide has seen to reduce almost 42% exacerbations in COPD. There have been two trials, the AZISAST and AMAZES trial, which shows that azithromycin treatment reduced exacerbation rates significantly, but they have the chronic use of macrolide has to be taken with care because they may cause hearing loss, hepatitis, diarrhea, and QT prolongation. We see that apart from azithromycin, not a lot of work has been done on other macrolides, that but still the side effect profile should be kept in mind when using in these patients. The other medication which is upcoming or already established in the sense of role of PDF inhibitors, they inhibit neutrophil function, they decrease the expression of MucFI expression, improve ciliary motility. They have an established role not only in asthma and COPD, but in echo also. These particular phosphodiesterase inhibitors have a good role and a proven role to play. Particularly, drugs which are of note are roflumilast, a primarily selective oral PDE4 inhibitor, theophylline, which is a old generation non-selective PD inhibitor, or the newer ensifentrine, which is a dual inhalational phosphodiesterase 3,4 inhibitor. All of them help in several sort of echoes associated with a predominant COPD phenotype, like COPD with CAD, COPD with small airway disease, with OSA, with super exacerbations. All of these phosphodiesterase inhibitors have shown to play a positive role. Non-pharmacological management of echo includes regular physical activity should be advised, a healthy diet, weight loss is always good, whether it be any type of echo, avoidance of known triggers, caution in using aspirin. They should be advised pneumococcal influenza vaccination, pulmonary rehabilitation, and even bronchial thermoplasty has been indicated. So I would like to end this presentation of mine by thanking you for a patient listening, and I would like to say that in echo patients, usually as compared to the other patients, there will be more respiratory symptoms, a relatively worse quality of life if we don't identify them. They will have more physical impairment, a higher risk of exacerbation, and more healthcare utilization will be there. So we should commonly be ready to identify them and take care of them in a very different way from our routine patients. Thank you very much for this opportunity.
Thank you, Dr. Dosi. That was a very comprehensive talk covering every aspect of the condition, variously named, as you said, asthma COPD overlap syndrome, asthma COPD overlap, COPD plus COPD A, asthma plus COPD. And one of the best descriptions I saw was, should we call it asthma, COPD overlap, ACOS? Should we call it CAOS? Or is it all chaos? And in the nomenclature, certainly it's chaos. However, I think you've given us a very good idea that there is truly a set of patients who have features of asthma and COPD, behaving differently from the other groups, pure asthma or pure COPD. And we need to identify and treat these patients because they have worse outcomes, more complications, more admissions to hospital, and overall more expenditure to person, to family, to the healthcare system, and to the country. So this is an important group we should pick up. So we have an excellent panel to take us through these, same questions. And you were given only 20 minutes and you've done a masterly job in covering all these. But we'll have a little more time to explore these questions in a little more detail. So we have an excellent panel today, starting with Dr. Kinjal Modi. He is a consultant pulmonary physician, currently practicing at the PD Hinduja Hospital and various Western suburb hospitals in Mumbai. He has several national and international publications to his credit. He's an active committee member of various medical associations, both medical, pulmonary, and bronchology. He's also very interested. No, can you go back to that, please? Yeah. He's also very interested in the medical legal aspects, and he's a member of the Medical Legal Society of India. But most importantly, in my opinion, these are what characterize a person because we're all pulmonologists. He's also a marathon singer, a marathon runner, a singer, a poet, and a YouTuber with around 100 videos on his channel. So, yet another rock star in our midst today. Our next panelist is Dr. Kiran Rami. He is the professor and head of department of the Department of Respiratory Medicine at GMERS Medical College and Hospital in Ahmedabad, Gujarat. Dr. Rami, welcome to this group. Looking forward to hearing from you. Our next speaker, panelist, is Dr. Richa Jindal Gupta. She's from the Delhi NCR region. A very short introduction. But that's
my name is Shikha.
Sorry, this is Shikha Jindal Gupta. I'm so sorry, this came up on that. And Dr. Shikha, unfortunately, was not on the group, so we were not able to get more details. But Dr. Shikha, I think we all know you and welcome to this panel.
Thank you.
And our last panelist, apart from Dr. Ravi Dosi, who's already been introduced, is Dr. Priyanka Ghosh. She has done her MD from Calcutta in respiratory medicine and DNB respiratory medicine from Delhi. She's an assistant professor in the College of Medicine and the Sagar Datta Hospital. And she's also a consultant pulmonologist at the ILS Hospital at Dum Dum in Kolkata. So here's our excellent panel. And we look forward to very interesting discussions on this rather controversial topic. And you know it's controversial because, as Dr. Ravi Dosi was pointing out, we even had a separate, handbook in the 2014-15 asthma guidelines or GINA report and the gold report. And now it's been left out in the last couple of years because there's so much confusion on this topic. So let us explore this in greater detail. My first question, can we...
Sir, I would not like to miss this opportunity to introduce respected Dr. B.V. Murli Mohan sir. Sir, you are a senior consultant and director, Department of Internal Medicine and Pulmonology at Narayana Health, Mazumdar Shaw Medical Center, Bengaluru. Sir has multiple orations and fellowships. He has published more than 100 papers. But what is more relevant, whenever you are finding something very reliable on the net, you see Dr. Murli Mohan sir's name attached to it and you automatically take up that particular thing as original. So I am really obliged to be a part of this panel, sir. On behalf of everybody, a big thank you.
Thank you so much for that kind introduction. Let me start off with, a question to Dr. Kinjal Modi. Dr. Kinjal, we've heard about asthma, we've heard about COPD, we've heard about ACO. In your mind, what are the important features that characterize asthma, COPD, and when should we say, I don't think this is pure asthma or pure COPD, I think this is ACO?
Thank you for the question, sir. Am I audible, sir?
Yes, you are. Yes, you are. Thank you.
At the onset, I'd like to thank ICS. This is my first webinar on ICS. Very grateful to Dr. Chawla and Amita Madam to have me on this platform. Fantastic questions, basically. And Dr. Ravi Doshi has done a fantastic job in giving us a whole brief about echo. See, definition point of view, Dr. Ravi has covered very nicely. But for me, just to give you a brief idea, I would like to correlate with something called as airways are like roads. So asthma, we all know it's a reversible airway disease. So airway disease, which is basically which can be reversed, simple is asthma. Which cannot be reversed is COPD, and with some reversibility is like echo. So if we just want to have a corollary with the roads, so if we have some kind of obstacle, like where we're traveling with a car and some accident is across, we know that some point of time it is going to reverse. So we'll go through. That is something like asthma. Unfortunately, if you have dividers or bumps, they are a fixed obstruction, which we know we have to wait and go through. We cannot avoid them. That is like COPDs. And aqua are like potholes, which are there many in our Mumbai. So basically now, no, not our BMC is working on it, but they are like obstructions which may be reversible, may not be, and they're more troublesome than anything else. So that is what the things are, we can say, sir. In short, thank you, sir.
Great. That's a nice and simple explanation. The cornerstone being the reversibility that happens from almost completely reversible to poorly reversible to something in between. And very interestingly, you said that you get more trouble when it's only partially reversible. So you continue to have some obstruction and you still have to work your way through this. I'm very glad to hear that the Brihan Mumbai Corporation is working on removing these obstructions. Thank you for that humorous introduction and explanation, Dr. Modi. We go on to Dr. Kiran, Rami. You know, we've spoken about this. I've already referred to this. Dr. Kiran, ACOS, ACO, COPDA, asthma COPD, which term should we prefer and why? You're muted, sir.
Thank you very much to Dr. Amit Anand and Dr. Murli, sir. This is my first webinar from ICS side. So I'm very much thankful. And it's a wonderful presentation by Dr. Ravi Dosi, sir. So the question is echo, COPD, asthma and COPD, which term we should we prefer? So the asthma COPD OLF syndrome, asthma COPD is OLF, COPD-A and asthma plus COPD. So it's both, all the terminology are the same. So it's a chronic inflammatory lung condition, obstructive airway disease, in which both the features of asthma and COPD are. So mostly we combinedly care is asthma COPD OLF. So it's a great terminology.
Great. So you notice that, you know, when the gold guidelines or gold report, I keep calling it guideline when they themselves say it's not a guideline. When the gold report comes out, they use the term COPD-A. So clearly the emphasis is there on the COPD predominant variety. And if the GINA report comes out, they say asthma plus COPD. So does this mean that if the problem is predominantly COPD, we should call it COPD-A? And if the problem is predominantly asthma, we should call it asthma with COPD, highlighting that the reversible component predominates or the non-reversible component predominates, whichever we are using. Do you think that's an acceptable solution to this confusion?
Yes, sir. Yes, sir.
Great. Thank you so much. Dr. Shikha, my apologies again for using the wrong name for your introduction. Dr. Shikha, what percentage of patients you see in your practice have this ACOS or ACO?
Good evening, everybody. So first of all, I would like to thank ICS, Amita Nene ma'am, and I'm so sorry for joining the last minute because I was unaware about the group. So, sir, the patients which I see in my practice is actually I did one, means we are still doing enrolling patients of a cause of both asthma and COPD, considering that which has asthma COPD overlap syndrome. And if I see the asthma phenotype predominant patients, so among asthma, I see approximately 20 to 25% of patients who have a cause. And we consider, if we take a COPD, so if we consider COPD as the denominator, then we see again a similar kind of thing, approximately 25 to 30% of the patient as a cause. So this is what we are observing right now, and we are still doing it.
Excellent. You know, we have almost the same data. one of our postgraduates, now a respected consultant in Kerala, did her study on, differentiating between asthma and COPD, predominantly using FeNO. And what she came across was almost similar figures. I remember it was around 23 to 25% of, I don't remember the exact figure, but it was in that range that you're mentioning. So that's far higher than the international figures that are given to us. I don't know if this is something that is peculiar to India, because you must remember that Dr. Sandeep Salvi, our respected, researcher, pulmonologist, has said that non-smoking COPD actually accounts for a vast majority of patients with, obstructive airways disease in India. So I don't know if, some of these actually should fall into the ACO group that we are talking about. So very interesting data from you. Thanks, Dr.
What you said is very true. Probably we don't have much data of echo from India, and since we have many exposures, especially the environmental, the pollution, the biomass, so probably we are having more echo patient as compared to what the Western world is having.
Completely agree with you. Yeah, absolutely. So, which is again something very important. We need to highlight the importance of getting our own data, our own research. So, Dr. Ravi Dosi, as somebody representing the ICS, also here, and of course, Dr. Amita in the background. Maybe we should launch many more registries for all these conditions under the leadership of the ICS. Here's a plan for the future. Dr. Priyanka, are there genetic differences that will help us differentiate between these three conditions, asthma, ACO, and COPD?
Yeah, thank you, sir. First of all, thank you, Dr. Chavala and Dr. Nene ma'am, for giving me this scope. And thank you, Dr. Mohan, for it's my honor to be a panelist under your moderatorship. Regarding this particular question, it is the age-old said term that asthma and COPD and echo all these things are at all a different disease or a different nomenclature only, as because there is a strong genetic correlation between these diseases. There is significant genetic loci overlap between this asthma, COPD, common loci present in both asthma and COPD, and also overlap with the traits of related to the asthma, such as the eosinophil count and asthma. Particular single loci overlap is there, but the genome-wide association studies, that is the GWA studies of echoes, they have revealed some distinct genetic influences for echo, which signifies that there is genetic overlap significant between the asthma, COPD and echo, but echo is not simply a combination of asthma and COPD. Particularly regarding the HLA-DQB1 gene, these genetic foci derangements have a significant association between the echo and airflow obstruction. And particularly chromosome 5 intergenic signal, this area is particularly linked to echoes, which is not related, is not present in asthma and COPD at all. So there is a significant thing that these genetic mutations or genetic loci changes are particularly related to echo, which signified this is not just to overlap between the echo and COPD, rather it may be a distinct, significantly distinct entity.
Absolutely. Different phenotype, but also different endotype underlying it and a different genotype underlying it. Very well explained, Dr. Priyanka. But is it important to label these conditions? Dr. Ravi Dosi, coming back to you after your excellent talk, Professor Alvar Agosti has used this term treatable traits, and he says, why bother about labels? What the patient is interested is in getting better. So we should identify some treatable traits and treat those. However, having said that, is it still important to identify what is asthma, what is COPD, and understand the clinical features that characterize ACO as opposed to asthma and COPD alone?
Thank you, sir. A very excellent question, and actually summarizing all that is difficult with echo is basically labeling. Now, asthma and COPD, from day one in our postgraduate clinical medicine or respiratory medicine, we are taught that we have two extremely distinct entities. But at the same time, you see patients who might be predominantly middle age. They might be having airflow limitation, which is partially reversible. It never fulfills the criteria, but it's just at the border. You see that there are patients like exertional dyspnea in them, but it is variable. It can be a persistent exertional dyspnea, but it is still variable. Patients might have had symptoms since childhood, or he might even have a history of starting smoking early, having significant childhood pneumonias, which might be there. It might be a person who has substantially improved initially with treatment, but now finds it difficult to respond to treatment. There can be patients who exacerbate so commonly, but at the same time, they exacerbate and they respond within a day of steroid usage. They can be symptoms which require treatment much more than their peers, which is quite unexplainable because they might be non-smokers. You might see chest X-rays which just show hyperinflation. Patient might not be a non-smoker, but still they behave with a fixed V's and a poorly reversible pattern. Then, most importantly, if you go in for sputum cytology, you might see eosinophilia or neutrophilia in the wrong group of patients, in the reverse group of patients. These are a few characteristics where you often tend to think that, hello, is asthma COPD actually there, or there is something which is a khichdi of both of them? And that is when we actually think about echo being present. And as a practitioner, I see that a lot of patients actually fit into this criteria. So I feel by actually discussing this topic, all of us are actually addressing a very important facet of our practice. We need to identify these abnormalities and not take them lightly. We shouldn't treat them just like that. Although labeling can be harmful, you should never be it should not be a watertight label that I will not do this in asthma, I will not do this in COPD. We need to understand if there are some factors which we can work on, identify them and treat them relevantly.
Excellent answer. And of course, with the recent study showing that single inhaler triple therapy seems to be extremely useful in patients with COPD, especially in the COPD-E group, maybe these labels are very important, but we, as you said, should not make watertight compartments of each of these. And we need to identify the traits in these patients and handle them specifically. Thank you for that. Dr. Kinjal Modi, in patients with COPD, there is a recommendation for recommendation for use of inhaled corticosteroids in 3 groups of patients.
Hello, Dr. Murali, sir.
Hello.
Sir, you are on mute, sir.
Hello.
Hello, Dr. Mohan, sir.
Murli sir, I think you are on mute.
Am I audible?
Yes.
My apologies.
thank you,
Yeah.
sir.
So
Yes, sir.
that was an excellent answer. I'm going to go quickly to the next one. So the gold report suggests that patients with COPD who have high eosinophil counts, more than 300, patients who are frequent exacerbators, and patients with a previous history of atopy actually do well with inhaled corticosteroids as part of their therapy. So is this actually an ACO phenotype, Dr. Kinjal Modi?
Yes, sir. So basically, yeah, fantastic question again, sir. So thing is, this has there's two separate. Means your question was fantastic, having two parts in it. One is a small of definition that basically that we have that expert panel has told that should be 3 major and 1 minor criteria has to be covered. So you have in the question you have covered very nicely that eosinophilia is there, atopy history is there, some COPD is there. So fantastic. Basically, all the 3 major component is covered and atopy also is covered. So basically, ACOS definitely it fits in. And Dr. Ravi has shown a fantastic slide, if you remember, in his presentation, that if we have the symptoms or basically atopy is there, means the ACOS symptoms going more towards asthma side, definitely ICS comes in picture very nicely, sir. We have to definitely include ICS. If it is more towards the COPD side, then definitely we can include it on the later date. But definitely including ICS in ACOS will definitely reduce the exacerbations and will improve the patient better. So I'll definitely use it, sir. Thank you.
Thank you. The other question that comes up is, now we've actually explored what is ACO, what is asthma, what is COPD, and how these move fluidly one into the other, recalling what was long ago debated as what is called the Dutch hypothesis, that these are just different expressions of the same disease. We know that's probably not true anymore, but we also recognize that there's a lot of overlap between these different conditions, whether we label it as such or not. But what we use very often as the starting point for differentiating between these conditions is lung function testing. So, Dr. Kiran Rami, what is the difference in lung functions between asthma COPD and the other obstructive airways diseases? I'd like you to take us through this gamut of lung function tests that help us in this differentiation. Dr. Kiran, you're muted. Can you unmute, please? You're again muted.
Sir, I have sent request to you, sir. Please accept it.
Request to whom?
To
Uh,
Dr. Kiran.
Dr. Kiran, sir. Sir, I am sending request to unmute yourself, sir. Please accept that request.
Dr. Kiran, you'll have to. Now you're unmuted.
Hello. Yes, other obstructive airway diseases like asthma, COPD. We all know the pulmonary function test, lung function test. Asthma, we have the normal spirometry, near normal, and fully reversible. It's a good post-bronchial reversibility in case of asthma. In case of COPD, we all know the FEV1 upon FVC is less than 0.7, airflow limitation, and there is a limited and minimum reversibility in case of COPD. But in case of echoes, what happen? It's a combination of both asthma and COPD. There is a persistent airflow limitation is also there, like COPD, and significant bronchodilator reversibility. As Dr. Ravi says in his talk, there is a 400 ml reversibility is there. So there is a basic difference in asthma, COPD, and echoes patient. So echoes patient having FEV1 of FVC less than is 0.7%, but there is a good post-bronchodilator reversibility is there. Thank you.
So this FEV1 FVC ratio, I'm going to ask both you and Dr. Ravi Dosi this. Does this refer to pre-bronchodilator FEV1 FVC ratio or post-bronchodilator FEV1 FVC ratio of less than 0.7?
Post-bronchodilators.
Post-bronchodilators.
Post-bronchodilator. So they have persistent airflow limitation, very importantly, but
Yes.
they've also exhibited a significant amount of reversibility.
Reversibility is there.
Yeah. What about the other lung functions? Are there any differences in the other lung functions like the diffusion capacity, the air trapping as evidenced by the RV by TLC ratio and so on? Are there any differences that you'll pick up if you go beyond spirometry and look at, say, body plethysmography and diffusion studies?
Yes, it's like a COPD. It's like a COPD. In RVT, PFTV DLC is also in some cases they reduce.
Okay. And again, will it help you differentiate between the COPD predominant variety and the asthma predominant variety, where you hardly get any change in DLC or you actually may see an increase? Then it points you more towards asthma, whereas you get a significant decline, it points you towards COPD.
COPD.
Yeah? Okay. Thank you. But more and more these days, we are using impulse oscillometry or forced oscillometric techniques. So, Dr. Shikha, does iOS or FOT have a role in differentiating between the obstructive airways diseases?
And yes, hello, sir. Sir, FOT cannot replace the PFT. So I would still want PFT for all the patients if I think of a chronic airway disease in such patients. But yes, I should say the basically FOT we see few things. One is the resistance, reactance. So both the things are important. So especially in patients of asthma, the early asthma patients or patients with early COPD where we are not able to document the FEV1 by FVC ratio less than 0.7. But in such patients, if we see that R5 minus R20 is very much elevated, which is suggestive of small airway disease. And also we see in such patients the airway, the area under the curve and F frequency, which is also increased very much in both asthma COPD patients as well as in ACOS patients. The most important thing of FOT, which I feel is, especially in patients with cough variant asthma, where the PFTs are normal, where we see when we do the FOT in such patients, we see small airway disease in such patients, and also we see significant reversibility. We very well see such a good reversibility, which we don't even see in the normal spirometry. And these are the patients in whom we can give inhaled corticosteroids, and they respond very, very well. So I feel the FOT is very good in such patients where we have a challenge of diagnosing small airway disease in the normal PFTs.
The other problem, of course, with spirometry, I agree with you completely. Spirometry is still the gold standard.
Yes.
Every effort should be made to get spirometry. You do not get a lot of important data like the FVC and so on when you do impulse oscillometry or FOT. The problem is many patients are unable to do it. And I would estimate that almost 30% of my patients with more advanced lung disease are unable to do spirometry. And that's
Right,
where,
sir.
as you said, the impulse oscillometry or forced oscillometric techniques come in. And I think, as you said, we pick up small airways disease better. But as Professor Chabra will always tell you, we don't really have normative data properly for iOS or FOT. So
Right.
using this to differentiate between ACO and asthma or COPD is actually not very evidence-based. However,
Right, sir.
in clinical practice, very often we are forced to use it, and that's where we use, we will probably have to explore this even more. But as you said, you get huge improvements, especially in the AX. You get very nice improvements in the AX, to some extent in the FRES also. So yeah, I think it's a very useful area, and I would love to see somebody doing a study comparing the two in all these conditions. Yeah, and of course, most importantly, establishing some normative data for us. I mean, Dr. Chabra has a very, very important role to play in this discussion. Actually, we had this discussion some time ago, and he is a complete skeptic about iOS and FOT, and with good reason.
Yes, sir.
Absolutely. So, are there criteria to make this diagnosis of ACO? I'm going to call it ACO for convenience. No matter what the label is, I'm going to call it ACO through the rest of this talk. Are there criteria, Dr. Priyanka, to make a diagnosis of ACO? And are biomarkers important in this differentiation? Because we've already heard about lung function tests. And is there any consensus on these criteria? Dr. Dosi told us he referred to about 15 different papers or 18 different papers, and they were all, very little correlation between all of them.
Yes, sir. Again, Dr. Doshi have presented the slide which contain the eco consciousness said that three major criteria and at least one minor criteria, that age at least 40 years and permanent airflow obstruction, that is post FEV1 AVC less than 0.7 or lower limit of the normal, and the at least 10 pack years of smoking and history of asthma before 40 years, that is the or more than 400 ml, more than equal to 400 ml, and 15% changes. Minor criteria are history of atopy or allergic rhinitis, 200 ml, 12% changes, and blood eosinophil count more than 200. But if we can see that in all the criteria, again the PFT is very important. Other than that, regarding the biomarker, other than the PFT, the biomarkers, the commonly used biomarkers are again the IgE and the FeNO and blood eosinophil count and sputum eosinophil and neutrophil count. But again, this biomarkers are not 100% sensitive again, and if the sensitivity is quite high, but specificity is not that high, because asthma is a type 2
Disease.
profile.
Yeah.
So it is type 2 profile. So it is eosinophil mediated and IgE mediated. So FeNO is comparatively higher in non-smoker inflammation. So it is comparatively higher. But it is seen that this profile, obviously IgE and FeNO and blood eosinophil count, these are higher on the asthma side. But again, on COPD patients on exacerbation will show the higher eosinophil count also. And FeNO not up to that higher level can be seen in the COPD as well. So there are few biomarkers which are under study, which can in future show some lights to the differentiation between the asthma and COPD. Some of them are YKL40, which is higher in COPD as well as asthma. So it is seen that there is no particularly significant correlation of the YKL with the asthma or COPD in studies, but distinguishing asthma from the echo, rather echo from the asthma, MMP3 and IL-1RA, these are very two important significant biomarkers that can be studied in future, because these are very specific for echo as compared to the asthma, and they are not seen in the COPD at all. So these biomarkers can be seen promising in the future as well.
Absolutely. And I think there are other things also like periostin and NGAL
Periostin.
seem to
But
be very
periostin is,
interesting.
yeah, yeah,
Yeah.
sir.
Go ahead.
Periostin is not very it is not very correlated. In studies, it is seen that it is not very correlated with the asthma and COPD. So the MMP3 and IL-1RA, these two are the biomarkers which are very much related to echo as compared to any other disease.
So very interestingly, in clinical practice, what we tend to use is still spirometry and pheno. So again, the postgraduate I was referring to, now a consultant, showed that at a cutoff of more than 22.5 is when you thought of echo. If it was less than 22.5, it was predominantly COPD, going by the then gold criteria and the GINA guidelines. And if it was more than 50, you were almost sure that you're dealing with asthma. So between 22.5, some people use the cutoff of 25, but our study was 22.5 to 50. You were most likely dealing with ACO. And we found that fairly useful because it is a very good marker, as you mentioned, of eosinophilic inflammation. Do sputum eosinophils have any role? You come from the city where Dr. Angira is doing a lot of sputum studies for eosinophilia.
Sputum eosinophil have a significant role, sir, but in particular areas where the sputum eosinophil count is done properly and the reports are available, it is really a very difficult test to do in our regular setups. It can be reliable if we have we send the sample to the reliable center and we have a reliable reports. Only depending on that, and we have to get this separately. But blood eosinophil count, we can day-to-day practice, we can rely on the blood eosinophil count. We can have a idea about, but not say absolute eosinophil count. We have to get it separately, definitely.
Absolutely. And the problem is, when a patient is on inhaled steroids already, you will get changes in both the pheno and the eosinophils. So,
Smoking and
sputum
steroid both
eosinophils.
will change.
Absolutely. So, we need to take that into account when we're trying to interpret these biomarkers. Thank you, Dr. Priyanka. That was a very comprehensive answer. Going back to Dr. Ravi Dosi. Dr. Ravi, you mentioned this while you were talking about, during your lecture. Are there radiological differences that help you differentiate between these three conditions, ACO and the other two major obstructive airways diseases?
Well, sir, first of all, there are no defining features of echo. Echo can be picked up by several contributory features, like usually in imaging in asthma and COPD, we tend to look at airway narrowing, what is the thickness of the airway wall. We like to look at emphysema, what is the pattern and severity of the emphysema which is there, or is emphysema there or not there. And we try to quantify airway trapping in expiration by mosaic attenuation, or by the combination of these three we might find echo, but there is no diagnostic criteria. There are several research tools in MRI with the help of helium or xenon, which help us to visualize some pulmonary ventilation and diffusion abnormalities. But again, I think the best we can do is maybe a patient in which we are suspecting asthma, and on the CT we get an emphysematous pattern. I think it might be that clinico-radiological combination which might give us a diagnosis in echo.
Absolutely, absolutely. Can't agree with you more. So you have a patient you think has asthma, and then when you do the CT, or the CT has been done, and you see a lot of emphysematous changes, centrilobular emphysema, you say, oh, this can't be purely asthma. There must be an element of COPD. So we're talking about an asthma-COPD overlap. Again, if you find that a patient has predominant COPD, you find more of larger airways involvement, larger airways thickening. You tend to think, oh, maybe there is a significant element of asthma. So while radiology cannot give you the answer by itself, I think it can point you towards the correct diagnosis when you combine it with clinical, picture as well as the lung function test. So great answer that. Thank you. Most importantly, Dr. Kinjal Modi, do you think that these three conditions, Dr. Dosi already told us that outcomes are often worse in ACO as compared to asthma and COPD. What are the differences, and why does this happen?
So basically, if you remember the first question when you asked me, I gave a very nice answer that partial
All your
obstruction.
answers are nice. Thank you.
Your moderation is fantastic, sir. Basically, that's why. Yeah, that's all things are great for us. So, thing is that potholes, what corollaria gave now, that was more troublesome than other obstructions. Similarly, basically, to make you understand that if there is an echo and a patient having COPD and a patient having asthma, So if all three taken together, only COPD, only asthma have less complications, less problems compared to echo. Now things are why it is that. The Gibson with the first person when he brought it out, which was spoken by Dr. Ravi in his slides in 2009, that he said what he observed more symptoms were there. That is number one. More symptoms were there with echo. Number one. Number two, that basically that is a fall in FEV1. That is a lung function deterioration. And number three, that is frequent exacerbations. So three things are more in echo patients compared to asthma and COPD alone. So at the end of the day, we have a worsening of disease by itself, more worse basically in echo. So the patient deteriorates faster with echo compared to alone a COPD or asthma. So thank you, sir.
Thank you. Dr. Kiran, Dr. Kinjal Modi has just spoken about pulmonary complications, but he's left the extrapulmonary complications of echo to you. So what are these extrapulmonary complications? Are they more likely to happen in echo than in asthma or COPD, and why?
Yes, sir. Yes, sir. It's a very good question. So pulmonary complication, we all know the extra pulmonary complications are the cardiovascular complication related cardiovascular disease. It may be ischemic heart disease. It may be heart failure, right-sided heart failure, or some patient having a left ventricular failure also. Cardiac arrhythmia, atrial fibrillation are more common due to hypoxia. Patient having a posterior hypoxia, then it may be lead to atrial fibrillation. Some patient develop hypertension. Prolonged use of steroid that leads to osteoporosis and skeletal muscle weakness. So use of long-term corticosteroids. Mental health disturbance, a patient having a dementia and some patient develop depression also. Prolonged use of steroid that leads to patient developing diabetes. Some patient having a eye-related complication like glaucoma also. Prolonged use of steroid and that leads to patient having some GERD-like complication, gastroesophageal disease also. Muscle wasting and some nutritional related disease, there's patient developing some iron deficiency anemia also. Or in rare possibility, there pulmonary embolism also it may be possible.
Absolutely. So we must be aware that echo, like COPD, tends to have more systemic complications. In asthma, you tend to get predominantly pulmonary issues. Not that you can't get systemic issues, but extrapulmonary complications are much more likely in COPD and in echo.
In echoes, yes.
Absolutely. So, that's something that becomes very, very important. You also mentioned the problems with treatment. So, Dr. Shikha, you've made a diagnosis of echo. What is the best way to manage echo, and how does it differ from your management of patients with asthma alone or COPD alone?
Well, I think, sir, Dr. Ravi Dosi has very well taught us about the management, the way he has endotyped and phenotyped the patient into the 4 groups. So that was just wonderful. So, sir, if one thing is that you diagnose as an echo and you start ICS plus LABA, and gradually, as what is there in the GINA guidelines, stepwise, you just increment till the level till the level 5. But if we are able to endotype and phenotype the patient, as sir has told, like if we have an echo A group, which predominantly consists mainly of asthma and female patients, and they are non-smokers. So in such patients, we can consider low to medium dose ICS LABA in such patients and gradually increase if their symptoms are not controlled, and then it can switch to triple therapy. The second group is again an asthma patient, but these asthma patients are smokers. That's a B group. And in such patients, again, you start with medium dose of ICS LABA, and gradually, if the patients are not controlled, you switch to a triple therapy. Then comes the COPD predominant group, which are there in later age, more predominant in males. So in such patients, if the patients have a COPD with eosinophilia associated, such patients you should consider a triple therapy in such patients. And the fourth group, which sir told, was the COPD patients which don't have eosinophilia, but they have reversibility. In such patients, you can give LABA LAMA, but I feel that again, these are the candidates where you should give a triple therapy in such patients. And then comes the role of other drugs like biologicals. If you feel it's similar to the asthma, if the symptoms are not getting control, again, it's a severe echo, though this terminology is not there. If the symptoms are not getting control and they have T2 type, T2 high inflammation, in such patients, you can consider dipolizumab or mepolizumab because the trials are there and they have shown good results in such patients. And again, a role of macrolides in patients where you feel they have more like a bronchitis kind of a this thing. In such patient, you can give macrolides as well.
We're going to be discussing the biologicals in more detail a little
Right.
later. Thank you so much for that. But, we always focus on pharmacological therapies. Dr.
Yeah.
Priyanka, what is the role of non-pharmacological therapies in patients with ACO? You're muted, Dr. Priyanka. Can you unmute, please?
Sorry, sir. Just like the COPD management and asthma management, non-pharmacological management is obviously very, very important for echoes management, obviously. So most important for the non-pharmacological management is lifestyle modification. If we go back to Dr. Doshi's first slide, that what are the factors which influences the further development of echo in future life, all the things are hidden there. The most important thing is quit smoking. It is the most crucial non-pharmacological management, even more important than the pharmacological management is non-pharmacological management, quit smoking and avoid all
I'm
the
going to
triggers.
interrupt you there just for a second. We've been talking about smoking, but we know in India, non-smoking COPD is very important and it worsens asthma. So let's not
Yes.
forget about occupational exposures.
That
That's
is I'm
equally
going to say
important. Yeah.
that is I'm going to say the next, sir.
Yeah.
So avoid the
Sorry. Yeah.
triggers. The no, sir, it's okay. So to avoid the triggers, that is the allergen, the cold, the any outdoor pollutions, occupational exposure, as well as the very important thing is now the passive smoking or the secondary smoking. To avoid that, good indoor air quality. Then the protection, that is the influenza and pneumonia vaccination for the COPD and asthma patient. It is also applicable here to get the protection. Then the rest of the thing is the rehab and exercise. That is also important in COPD, and just like that in EPOS patient also, to enroll the patient for any rehabilitation programs, daily day exercise. And the third thing is the balanced diet, proper nutrition, and few things like the avoidance of the aspirin related drugs and like this.
Absolutely. These patients, as again was pointed out by Dr. Dosi, is they tend to have a lot of sarcopenia like the COPD patients. And unlike the asthma patients, again, highlighting the importance, as you just said, of pulmonary rehab, nutrition, and so on. The latest Gold report highlights the 4M approach. So I think that's the same approach we need to follow when you're treating patients with ACO. So again, the important thing is you take the best elements of treatment from asthma, the best elements of treatment from COPD, and apply them for your patients with ACO, whether it's pharmacological or non-pharmacological. Now, once you've tried all this, patient is not getting better, Dr. Ravi Dosi, is the time to consider, are we going to use biologicals? So what is the role of biologicals in patients with ACO-ACOS?
Thank you, sir. Basically, well, use of biologicals in asthma, but that to severe persistent asthma is quite well established. So any echo with asthma responding to biologicals, we will expect it because then we will tell that it is mostly severe asthma, it isn't echo. The surprise comes when in COPD with a T2 inflammation or the COPD like a labeled echo, when we are out to work with biologicals and we get a response. So we have three biologicals which have been proven in several studies. Mepolizumab has been shown to reduce exacerbations in COPD, and then you have several trials for that also. Then there is benralizumab, which helps in preventing COPD exacerbations. There is the Terranova and Galathea trial to support that. And then you have omalizumab, which has been independently studied in the echo group itself, and it has been shown that those patients receiving omalizumab are actually having a very low exacerbation rate and an excellent symptom control. So definitely, while omalizumab we tend to associate more with the pure asthma sort of a condition, but in even echo sort of a situation, it is giving benefit. So I would tend to have that mentality that in patients where inhalation therapy is not working, number one, think about echo. Number two, definitely do consider a try of biologicals.
Absolutely. And there's also dupilumab, which we don't have yet. But when it comes, I think it's going to be even more useful than, Mepoli or Benrali. And of course, there's the very disappointing results we had with tezepelumab. We were expecting it works upstream and, thymic stromal lymphopoietin. Blocking that would, cover all the downstream things. Unfortunately, it hasn't worked really well. But I think we should expect more trials and look at those who have. I mean, that was in predominantly COPD. So maybe the ACOs will do better. And I frankly expect ACO patients will do better than COPD patients because you have much more of a reversible component. And unfortunately, we maybe are hesitant to start biologicals. We start them too late. Perhaps in this group who have a rapid downhill course, as you mentioned, as Dr. Modi mentioned, we have several exacerbations in these groups, and we know these biologicals work best to control exacerbations. This is perhaps a group where we need to start thinking of biologicals early to prevent damage, to prevent a rapid downhill course. So, great answer. Thank you. Dr. Modi, coming back to you.
Yes, sir.
We've spoken about, the different problems with ACO and its differentiation from asthma and COPD. Are there any
Correct.
other differential diagnoses you'd like to introduce? And how do you look for them? How do you exclude them?
Yes, sir. There are see, in a clinical practice, we have multiple book pictures of basically different diagnoses if you want to speak about. But practically speaking, two or three are more the DDs which we should keep in our mind when Dr. Doshi said the patient not responding well or basically not giving the proper response. First and foremost is congestive cardiac failure. We should remember that heart is very near to lungs. With the congestion and pulmonary edema setting in bronchi, there's called cardiac asthma was the previous term used for it. Basically, can mimic like airway disease. And yeah, definitely, then we have clear X-ray pictures to find out the diagnosis, pro BNP values, and all those things definitely can help, as well as orthopnea and the PND symptoms are there. So that is how we rule it out. Second one would be bronchiectasis. It's again obstructive airway disease, but generally has a small airway disease component with it. And that is why basically it behaves like abnormally because some infections are exaggerating, coming up again and again. And because of small airway disease, the obstruction part is there. That is a patient is very breathless. Now, in this, obviously, the symptoms definitely are very much coming again and again. But the clinical finding when we say it is clubbing and basal crackles, the coarse crackles, definitely there. And lastly, CT. 3Cs basically help in diagnosing the bronchiectasis. And CT scan, Dr. Amita Madam has given us fantastic talk in the TestCon that glowing finger, signet ring sign, and tram-like appearance. All these things give us a classical picture that is a bronchiectasis, various type of bronchiectasis that we can discuss later. And lastly, all of that say OB, that is obstructive bronchiolitis, which is generally associated with either some viral infections or some transplant-related issues. Definitely it is there. And yeah, on the CT it gives a mosaic pattern, so that can give us a clear idea of a bird appearance also sometimes. And that is why it can be easily differentiated from the other the differential diagnosis. But yeah, these three things to keep in mind while diagnosis your calls. Thank you.
Great answer. Thank you so much. There are a lot of questions in the from the audience, and I think we should take them up. I actually wanted to ask about unmet, what is the unanswered questions. We'll come back to that right at the end. But I think there are so many questions, some of which have already been addressed both by Dr. Ravi Dosi during his talk and in the course of our panel discussion. So I'll go to the ones that have not been answered. And there's an excellent question from Dr. Mehika, which says, how does ACO impact treatment adherence? That's something we didn't look at in the course of this discussion. So I'm going to go to Dr. Ravi Dosi for this. Dr. Ravi, how does ACO impact treatment adherence?
I think a very, very important question, sir. Truly, we should have delved into it a more. Even I am thinking in my presentation because, see, there are two aspects to it. One is a patient not getting relief from the treatment fully, and the second part is that treatment, the trust of the patient will eventually lose if he keeps on exacerbating, keeps on exacerbating. So I think definitely echo diagnosis becomes all the more important and not watertight compartmenting that in COPD I'll not use ICS. It's not like that. You should give a trial if it is justified, and maybe with the diagnosis of echo we will get better adherence because the patient will respond better. So I feel that makes more important echo to be diagnosed.
Any of other panelists, do you think that patients with ACO are less adherent to treatment or more adherent to treatment, or there's no difference between, the three major obstructive airways diseases? Anybody?
So may I?
Yes, please.
Sir, regarding just if the both the sides are there, if the echo patient is more towards the asthma, so patient will behave more like asthma, the symptom will be mm, sometimes it will be better, sometimes it will be worse. So patient will again adhere to the worst time and non-adhere to the better times. So this will further progress the disease because it is a comparatively rapidly progressive. And if the patient is towards the COPD side, then the patient will comparatively more adhere with the treatment just because the symptoms are actually progressive like the COPD patient. So there will be a better adherence to that inhalational techniques.
So, Dr. Shikha, you actually are studying some of these patients more systematically. So, what is your impression on, treatment adherence in patients with the ACO?
Yes, sir. The echo patients generally, what we have also seen, they are more symptomatic. Though we are trying to have a good treatment protocol for all these patients, we are trying to maintain them. But since we don't have much guidelines, like proper management guideline, how to step up or step down their treatment. So at times that becomes very challenging because sometimes patients are not adherent, then they become very symptomatic. So I feel that probably if we'll have certain kind of a guidelines, a nationwide guidelines, then probably we will be able to have a more better adherence in such patients. But probably we don't have guidelines because since we don't have a good pathophysiology of this disease per se as such. So definitely I feel that adherence is little less in ECOP patient as compared to what we see in asthma and COPD patients. Yes, sir.
Yeah, thank you. Dr. Anjana has asked this very interesting question, something that's very important to address. Why are LABA monotherapy and LAMA monotherapy insufficient in patients with ACO? Dr. Kinjal, do you want to take that? And anybody else who would like to come in later? Dr. Kinjal, are you there? Yeah.
Yes, sir. I am there, sir. Can you please repeat the question, please, sir? Laba and Lama,
Yeah. Why are LABA monotherapy and LAMA monotherapy insufficient in ACO?
Yeah. So basically in echo, it is not one disease. We have to understand that. It is a dual disease. So basically it has asthma component and COPD component. So giving only one, see, we understand that for COPD, we start with LAMA first, or the LABA, basically start with either of them. And basically for asthma, LABA works fantastic. We know that, but with the ICS. But in AGO, both of them are there. So we have to include both of them. So either means if it is a mild one, LABA with ICS can work fantastically in earlier case. If it's more COPD type of thing, then basically LAMA initially and LAMA with ICS in the later dates definitely going to help. So combined therapy and later on if it is severe disease, cryptotherapy also helps. Definitely is going to help. So alone in either cases won't be helpful in ACO. That you got to understand that.
Anybody else would like to come in on that? Dr. Kiran?
Yes, sir. It's a very good answer by Dr. Kinjal Modi, sir. We first the rule out the disease first and explain to patient regarding the disease. And but we stem the first our diagnosis of echo. It's a, and by history taking and our clinical examination and our lung function test. And then we go for our treatment part. As such, the LAMA is not only working and LABA is only not working. So both the combinations are better for the patient. And if patient have a more predominant asthma, then we add ICS. And it more predominant to COPD, then we add the LAMA plus ICS.
I think we've learned very well from asthma that you should not use a bronchodilator alone, that it must always be accompanied by an inhaled corticosteroid. So I think that very clearly tells us that other bronchodilators alone should not be used. In asthma and in ACO, using a bronchodilator alone without an inhaled steroid is actually dangerous. So I think it's very, very important to keep that in mind. And I think the earlier guidelines, when they were there, did tell us that you should not use these as monotherapy or even as combined LABA-LAMA. There must be an inhaled steroid. The big question is, what dose of inhaled steroid do you use? Do you go for the highest possible dose to get things under control, like we do in asthma? Or do you, like in COPD, keep the dose to an absolute minimum and withdraw it when the patient is, doing well and stable? Clearly, we don't do that. but we can try and reduce the dose. Unfortunately, as these patients are more symptomatic, very often you have to use higher doses of inhaled steroids. Dr. Keyur asked, what tests are you to rule out other diagnoses? I think Dr. Modi covered that very well. So we can go on to Dr. Karan's question. Again, an important question. Can ACO lead to respiratory failure? Dr. Priyanka, you want to take that? Can ACO lead to respiratory failure?
Yeah, echo has a rather very progressive kind of lung function deterioration. So just like any other disease which shows the lung function deterioration, patient can go into the respiratory failure comparatively much worse than the asthma alone because of the airway is much more compromised as compared to the asthma in echo. So it can go to respiratory failure, type 1 and type 2 both, obviously.
And also compared to COPD, because these people have more exacerbations, they
More
can also go to
exacerbation
respiratory
rates.
failure also. Absolutely.
Yeah.
Yeah. Anybody has any other viewpoints? Please come in. Otherwise, I'll go to the next question.
So definitely we have patients of echoes with respiratory failure, and over the time they do develop pulmonary hypertension. And I have few patients of my echo which are on LTOT also. So yes, definitely, because they have overlap syndrome. We know that it's a COPD and this, and definitely with more exacerbation because of the rapid decline of the lung functions, they can land up into respiratory failure. That's there.
And as you said, pulmonary hypertension is not uncommon in these patients. Very,
Yes.
very important. So the point you made about LTOT is also very important because that's what helps these patients, prevents them from going into respiratory failure in the long run and pulmonary hypertension in the long run. Dr. Suraj asks, can occupational exposures contribute to ACO? Dr. Ravi?
Well, most definitely, sir. It is one of the important points that needs to be covered in history. If there is an important exposure to any gas or any biomass fuel exposure is there, any smoke, any other dust exposure is there in the form of a trigger, then we definitely see occupational exposures contributing to echo. They need to be worked out, and it is an important non-pharmacological treatment measure.
Absolutely. Very well said. Including, we've seen temple priests, pujaris getting into these problems. They have an underlying asthma and they have this constant exposure, to fumes from the agarbatti, dhoop sticks, and other exposures, camphor and so on. And often in these very constricted small garbhagriha, so they have a very high exposure to concentration. That's another group we often neglect. So they can also present with echo. Dr. J has asked, what is the
One more thing, sir, the air pollution we are forgetting, sir.
Yeah. Air
Everywhere in
pollution is top of the list. Absolutely.
Was, sir.
You're luckily sitting in Mumbai.
Oh, sir. Mumbai also has great AQI, sir, because of construction going on everywhere.
So I don't know what the people in Delhi are suffering. I know I went for a walk in Delhi some time ago and it was choking. Yeah, so Dr. J has asked, what are the comorbidities associated with ACO? I think we've answered that question, but Dr. Mehak has a very interesting question again, which again, I will invite anybody to come in on. What are the barriers to effective ACO management? Very interesting question.
I think we ourselves are the barriers to effective eco management, sir. We
Good
need
one.
we need to understand that echo is there, echo is a reality, and it is not like X-Men thinking I am human and human thinking he can't be X-Men. Echo is there. We need to identify that you need to phenotype the patient properly. You have a full gamut of bronchodilator and anti-inflammatory therapy available. You should go ahead and find out why patient not responding and go ahead and treat that patient with what it responds.
Agree. Anybody else would like to add anything to what Dr. Dosi has said?
No, sir. Basically, Dr. Doshi spoke very nicely. The first is our own barrier. Second is basically that when the patient is not responding, think of other causes. That's what the basic thought process, all the whole webinar is all about. Asthma, COPD, everyone knows, means by heart. But ACO is the one thing which is forgotten many times. So remember that whenever a asthma patient is a smoker while taking history, oh, think of, is it echo? Or when a COPD patient, if he has some atopic symptoms for some family member giving a positive history of atopy, or himself having a skin allergy condition or allergy rhinitis, think of echo. That's only one thing, is think of echo. That's only one thing, sir.
Absolutely. And I think one of the important barriers is that you had this confusion from 2014 to now, 11 years, there have been so many different changes in the nomenclature. That's confusing doctors, and we don't know
Definitely.
what to label it. We're embarrassed sometimes to use the word ACO, the term ACO. So that is another major barrier. So I think sometimes it's useful. Fine, you have a label, but always think whether you're dealing with asthma or COPD or ACO, what are the treatable traits in this patient? So that needs that mind shift. And I really appreciate Professor Agusti for coming up with this terminology. Treatable traits. Think of treatable traits. That's what the patient is interested in. Dr. Vishwesh has asked the same question: what comorbidities are common? Interesting question from Dr. Aditya. How does ACO present in older adults? Is there a difference between, we use the cutoff of 40, between asthma and COPD as one of the indicators. Obviously, it's a fluid number. It's not a fixed barrier, 39 and a half asthma, 40 and a half ACO or COPD. But obviously, ACO presents more and more. Dr. Dosi showed that very interesting lifetime course of ACO asthma. So, Dr. Doshi, I'm going to go with you. How does ACO present in older adults?
More of a persistent airway obstruction sort of a feature will be there. They will tend to behave more like COPD patients with a persistent problem. There will be more exacerbations which will be seen in them. Poor control with standard doses. You will need to have more of doses, and there, depending on their type of inflammation, they might even have frequent infective exacerbations. Plus, the comorbidities like pulmonary hypertension, I presume, will be much higher in patients with older echo.
Yeah, that's been our experience also. Dr. Shikha, do you agree? More comorbidities?
Yes, sir. Definitely. It's more comorbidities, more fixed airway obstruction, less of reversibility. So definitely more poor responders. So they behave more like a COPD when we talk about. So they are more like a COPD because with over the time their airways are more remodeled. So they might be a poor responders to ICS also. So definitely they will be more challenging to be treated.
Absolutely. Yeah. And of course, it may not be COPD, but it is fixed airways obstruction, as you said.
Yes.
So you really get very disappointing results in the older patients. And they constantly are complaining of excessive sputum production, behaving more like the chronic bronchitis. So in some of these patients, it may be worth thinking about roflumilast as an alternative to the other things that we use. Yeah. Dr. Sriram has again asked, maybe it's worth exploring this a little further. Because he's added a word that I didn't use when I asked you the question, Dr. Priyanka. What are the future directions in biomarker-based precision therapy for ACOS? So precision therapy is the new term he's brought in, which is very important.
Biomarker-based precision therapy. So again, I have said the few biomarkers which are particularly will be for echoes. If we can identify those biomarkers in earlier life, so it will be helpful to modulate the treatment in future, to counsel the patient what is your disease, how to modify it, whether it is echoes or simple a case of asthma. We can make the patient aware that smoking will be much more harmful to you if you have a trait of this echoes. So you have to be aware of that, as well as choosing regarding the inhalational therapy, and that will be also helpful if we can identify the biomarkers from the very early stage, that is the MMP3 and IL-1R1 1RA in the earlier stage of the disease, that is in the childhood.
Absolutely. And I think specifically for biomarkers, you've already emphasized that important role of pheno and other things which help
Yes,
you
sir.
make
Yes,
a
sir.
differentiate between
Yes, sir.
these conditions. Yeah. But
Obviously.
further biomarkers, the more advanced ones, watch this space. There's a lot of research going on, but we
Yes,
don't
sir.
have exact answers for precision diagnostics in these patients.
Yes.
Dr. Soham, I think we've already answered this question more than once. Can ACO be misdiagnosed as either asthma or COPD singly? Yes. And how to diagnose them correctly? I think we've just handled that with a prior diagnosis on treatment for any one entity. So as both Dr. Modi and Dr. Dosi said, keep your mind open. Patient is not responding as well, then consider ACO. That is how you make that differentiation. But Dr. Sohm again goes on to ask a very interesting question. And I'm going to ask Dr. Kiran Rami to answer this. Does ACO lead to higher healthcare utilization than asthma or COPD alone? And what is the long-term prognosis for ACO patients? More healthcare utilization or not? What is the long-term prognosis?
Yes, we see the asthma patients, we see the COPD patient. When we see both the combined patient, asthma, COPD, OLAP, this you say. First, we stem the diagnosis of asthma, COPD, OLAP patients by our clinical examination, our radiological and our lung function, we diagnose these patients. The main comorbidity is we all know the related complications also. So we advise the patient to take proper treatment, proper management, and proper pharmacological management, proper non-pharmacological management also. So long term, if patient not taking proper treatment, the long term complication is more.
Right. Anybody else would like
I'd
to
like
add
to
to
add,
that?
yeah, I'd like to add few things, sir. While just going through literature, while I was reading for your questions, sir, basically I found it one fantastic thing. There was a study which was mentioning the in hospital stay and all those things, comparing to echo and asthma and COPD. They always said that length of stay is more with echo, number one. That is basically the frequency exacerbation again is more. Need for healthcare is again more. Three things are more. That is fantastic. But then again, that said that their complications, need for readmission, they have no relations. So basically, it is not that always a co-patient admitted once will always require frequent admissions. No, that is not the thing. But yeah, stay is longer compared to asthma COPD patient, and it is basically more use of use of healthcare facilities. Sir.
To some extent, you can anticipate this because, they are better responders to inhaled steroids than COPD patients, for example. Okay, so they may have a better response, and you keep them early on treatment, keep them on inhaled steroids for a slightly longer time, maybe introduce triple therapy earlier, then these patients are likely to do well. But I think this largely depends on making the correct diagnosis, starting the right treatment, and continuing.
Early, yeah,
Dr.
treat
Shikha, you
early.
wanted to add something to that?
Yes, so the similar thing that since these patients are more exacerbators, they have probably these are the patients who are requiring more of the high dose of inhaled corticosteroids, and so probably these are the patients who exacerbate more. So definitely this is going to increase the healthcare burden these patients. So that's what I told, that since we don't have some proper guidelines, first of all we are not able to most of the patients are not diagnosed properly as echo. So some people are just some patients are just being continued as asthmatics if they are not being phenotyped, or they have not done their PFTs, or they have not been clinically diagnosed well. So definitely I feel that echo patients have more health burden as compared to a simple asthma patient.
Great, thank you. So some of the other questions have already been answered more than once. I think Dr. Sawant asked what are the current preferred terminologies, and we've agreed that, while we use the term ACOS, then we move to ACO, then asthma plus COPD, meaning that this is just, two conditions occurring together and not really liking to use the term overlap. We don't currently have a preferred terminology. So I think that is where we are at the moment. And we should wait and see whether we can reach a consensus terminology for this. We've already discussed the clinical features that differentiate these conditions. And Dr. Anjali, we've also already answered how it differs from pure asthma and pure COPD. Dr. Joy, we already answered this question on why LABA-only inhalers are contraindicated. We showed that it increases mortality when you use it because there's a significant asthmatic component. And I think we've also handled the recommended pharmacological treatment strategy, both in Dr. Ravi Dosi's talk, and later Dr. Shikha, took that question up. But this is an interesting question from, Dr. Joy. Here, Dr. Joy asks, when should triple therapy be considered for ACOS? So, Dr. Ravi Dosi, you want to take that? Not should it be considered, but when should it be considered specifically?
Definitely, sir. We had discussed that once we phenotype these COPD patients who have eosinophilia, then they are the ideal patients which will benefit from in eosinophil count more than 300. I believe that was the cutoff. Then they will benefit most from SITT. Apart from that, COPD with even less eosinophils but not responding to your other line of treatment might be given a trial of SITT. So I mean COPD type echo.
Absolutely. So again, it's not enough to label a person as having asthma plus COPD or COPD-A. You must try and find out which of these four groups the patient comes into, and that will determine. But essentially what, seems to come across from all the groups is that these patients should probably start triple therapy early rather than late. And once you've started triple therapy, you look at the response, then you try and see whether you can start reducing the dose of the inhaled corticosteroid. Dr. Vishwesh asked a very interesting question again. We've answered what risk factors contribute, which Dr. Atif Patel has asked. But Dr. Vishwesh, I wish we'd answered this. During follow-up, what are the parameters that you should monitor? Dr. Priyanka, you want to take that? What parameters should be monitored in a patient on echo during follow-up? And you can
During
take
follow
the associated thing because Dr. Sharma has asked, how often should you repeat spirometry in these patients? I think those two are connected, so we'll take them together.
Yes, sir. Yes, sir. We should for in follow-up, we have the second question is the answer actually. We have to look for the symptomatic control. First of all, the patient's symptoms, whether it is controlled or not. If the patients are getting controlled, we can consider reduction of the dose of the steroid. How much is this the bronchodilator, whether we should increase or not? It depends on the symptom of the patient. How breathless is the patient? If the breathlessness is getting controlled, we can reduce the bronchodilator dose. If the patient is the symptoms are reduced, then we can start choosing reduction of the ICS also dose. And we should repeat the PFT in around 3 to 6 months. It depending on the condition of the patient. If we want to, the patient is not getting controlled, we should repeat it earlier to add whether we should go for the SITT treatment. And if the patient is symptomatically better and we want to, if he is stable for a reduced dose, then we can delay the PFT. Depending on the condition of the patient, we should repeat that actually after 3 to 6 months.
Absolutely. So one of the things I do, and there's no evidence for or against this, is if they have asthma predominant echo, then I tend to use the asthma control test for assessment along with, the other things that you
ACT.
mentioned. And if a patient has COPD predominant, I tend to use just the MMRC or the CAT test. The CAT test is more difficult to do, so I tend to, just go by their symptoms. But that's the other thing that you can use. Anybody else can come in on any of the questions. We are, past 10 o'clock. Dr. Amita Nene has kindly allowed us to go on till all the questions are answered to a maximum of 10:30. So I'm going to hold all of you back, unfortunately. Dr. Jay has asked again.
Just not a question, just a remark. Basically, we're almost nearing 2,000 attendees for this webinar. So it's fantastic one, sir.
Fantastic. It's
all kudos to you,
all of
Amita madam, and the whole group, sir.
Yeah, wonderful. So Dr. Jay has again asked an interesting question. I don't know if this was answered during Dr. Ravi Dosi's talk. How does echo prevalence differ between men and women? Dr. Shikha, since you have been seeing these patients, any gender differences in echo?
Sir, echo with more predominant of asthma type. So generally, it's more like a female predominance, I would say. A patient with more like a COPD are generally male predominant. That's there.
Excellent, excellent. That's what one would expect also. So
right.
Anybody else wants to come in on that, your experience?
Sir, many female patients, we feel shy in asking a tobacco history. We label them as asthma. They turn out to be tobacco on the third or fourth visit. And I feel that is why also we have a huge population where echo exists.
Absolutely.
Feel free to ask.
And also with increasing female smoking, the increasing amount of female smoking, we even don't ask for that also. But even school goers or college goers, early college goers.
Yeah,
so,
definitely.
we have to ask.
Hookah bar is also.
The other group is the smokeless tobacco users.
Vapes, yeah.
There's increasing evidence that
E-cigarettes,
can
vapes.
also cause COPD. We've always
Definitely.
asked for smoking. Smokeless tobacco is important. Yeah. So Dr. Farhan has asked, I think we've answered this. Is echo seen in non-smokers? Yes. How does their phenotype differ? I think Dr. Ravi Dosi has already shown us the 4 phenotypes. And one of them is, the smoking variety where there is predominant COPD. So I think we've answered that. What science suggests persistent airflow limitation in echo? Good question, but I think we've answered that. This is interesting. Dr. Tridib, I was wondering why you had not asked a question.
Yes, that's true.
Yeah, he usually asks some excellent questions. So here is his question. If variability of symptoms are more than echo, more likely than asthma, where patients may remain well for long periods. So I think that's more of a comment, but you all can comment on his comment. If it is echo, you get more variability of symptoms than asthma, where patients may remain well for long periods. Dr. Ravi?
Definitely, sir. What sir is commenting is that basically it is an asthma with a touch where there will be something happening in between. They'll not be all that symptom free or COPD who will be exacerbating very frequently. So I fully agreed with what Dr. Tadip says.
And we know that ACO patients have more exacerbations, so
More
undoubtedly they have
exacerbation.
much more variability. COPD patients, unfortunately, they may have exacerbations, but they have a baseline level of, respiratory limitation that restricts them. Whereas, as he says, the asthma patients remain well for very long periods. Excellent. I think we've run out of questions from the audience. So I'm going to stop at this point, request each of you to give one message or to our audience, which they can take away. And as I said, Dr. Ravi Dosi, your opportunity to lead a registry in ACO so we can do something through the ICS for you, Dr. Amita, Dr. Rakesh Chawla, and of course, our young man who celebrated his birthday yesterday, Dr. Rajadhar, who's an amazing researcher, and of course, Dr. Sandeep Salvi, who's the topmost researcher. Here is an opportunity for us to look at Indian aspects of ACO and is there a need for a label and how do we take this further? But Dr. Kiran Rami, closing remark, one sentence from you on what our audience should take away.
Yes, it's a very good discussion and very good presentation from Dr. Ravi Dosi. It's a very, very helpful for all our young leading chest physician and all our PG graduates. Thank you very much, sir.
Thank you. Dr. Shikha, one takeaway message.
Sir, echo, there are many questions which are unanswered. The pathophysiology still needs to be more elaborately to be understand the pathophysiology of this disease, and probably we'll be needing more longitudinal studies to study that. And as of now, it is very important to diagnose among obstructive airway disease that which patients are falling into ACO. That's most important, because if we diagnose them echo, so we can manage them better. And because these are the patients who are more frequent exacerbators, so it's important that they should be diagnosed well. We need to phenotype, endotype these echo patients further so that we can treat them even more better.
Absolutely. Great comprehensive answer. Dr. Priyanka?
In my opinion, if not on the first visit we diagnose a patient of echo, if a obstructive airway disease comes on the second visit, not controlled properly, we should again think of whether it is a echo or not.
So take the history, take exposure history, see what is happening.
Again, go back to the history, and
history is king, as my
we should revise our diagnosis whether it is echo.
absolutely.
Thank you, sir.
Dr. Kinjal Modi, closing
Yes,
remark.
sir. Just closing remark is first is fantastic discussion and moderation by yourself, sir. I have to comment on that. Number one. Number two, always my only comment is think of echo. Number one, think of echo while you taking history. Think of echo by having the diagnosis and while treatment. So basically, early diagnosis, early treatment will prevent the exacerbations and the complication of echo. That is why the early diagnosis is very important. Thank you.
Absolutely. And of course, we started with Dr. Ravi Dosi. We will finish with Dr. Ravi Dosi.
Definitely.
Sir, three things I need to say. First, it was an honor to be on this panel with you, and a big thanks to you and Dr. Amita Nine ma'am. Second, it's my anniversary today. I can't stop without giving a big thanks to my wife, because now we'll be going for dinner. So thanks
Oh
to
my
her.
goodness.
And third thing is, sir, if your patient is using your inhaler properly, if your patient is well vaccinated, if your patient is worked up properly, but still your patient is not getting well, then please think of echo. There is something we are still missing. That is what I would like to say.
Thank you. So I'll close thanking this brilliant panel. I think we had an excellent discussion. Points made by all of you were brilliant. Dr. Ravi Dosi is celebrating. It's your wedding anniversary, Dr. Dosi?
Yes.
Yeah, so
Happy
heartfelt,
anniversary.
Thank you.
wishes to both of you, and wishing you
All
many,
across the
many,
globe.
many more years together of
Thank you.
happiness, health, good health, and love. So I will just end with one, thing that we take from many other conditions, but it started with HIV/AIDS. Hit early, hit hard. And how do you hit early? By diagnosing it early. So always think labels don't matter. Does this patient have features of both these conditions? What should I do? Let me get it under control early. If we can do that much, I think we'll help a lot of patients and prevent them from going into the complications, pulmonary and extrapulmonary, that we discussed during the course of this meeting. So thanks to Dr. Amita Nene for, giving us this opportunity, for giving me the opportunity to, discuss this with this brilliant panel. Excellent questions from the audience. Most grateful to all of you. And more than 2,000 logins, is humbling to all of us. Of course, Dr. Rakesh Chawla and the entire ICS team, grateful to all of you for doing these, week after week. I'm truly amazed by the quality of all the talks that are coming through. And with that, wish you all a very happy December and looking forward to 2026. Hand it back to the, to the tech team. I don't know if Dr. Amita is going to be joining us for a few closing remarks. Otherwise, we'll close right now.
No, sir, I don't think she will be joining us. She's in
Great.
the delegate link.
Thanks, Aditi ji. You were most helpful. Thank you so much.
Thank you so much, sir.
Thank you. Thank you.
Thank you so much, sir. It was a
Thank
wonderful
you.
moderation. Wonderful.
Thank you so much. Good night, everyone.
Good
Thank
night,
you.
everyone.
Good night.
Bye.
Good night.
Bye.
Thank you. So with that, we are closing this link. Thank you.
Thank you.